Hi, and welcome to ICS Live Lounge. My name is Shannon Wallace, and I was the chair of a workshop that we just finished, the Comprehensive Evaluation of the Pelvic Floor. And it was a great 90 minutes that we spent together. So I am fortunate to have Anna Spivak and Leila Nashatian with me today. We're going to just have a conversation about our workshop and talk a little bit about what were our favorite parts and what we learned. So Anna, why don't you introduce yourself?
I'm Anna Spivak. I'm Shannon's partner at the Cleveland Clinic, Ohio, and I'm a colorectal surgeon, and my practice focuses on pelvic floor.
And Leila?
Yes. Hi, I'm Leila Nashatian. I'm a neurogastroenterologist, and I'm working in a multidisciplinary pelvic health center, and been very fortunate to learn a lot from this multidisciplinary clinical work.
That's great. So we have two experts and me, I guess, here today. And so if anybody has any questions, feel free to come up to the microphone and ask us about our workshop, and we'll kind of give a little summary and talk about it. So, this workshop I thought was really such an interesting addition to ICS because it was so multidisciplinary. We had a urogynecologist, two colorectal surgeons, a gastroenterologist, and a radiologist who all gave their input on kind of how they evaluate the pelvic floor. And there's lots of different modalities to do that. And so, all of us do it in a little bit of a different way. So kind of, what was your big takeaways, Anna, from this workshop?
Well, based on the questions from the audience, one of the biggest takeaways is that we all see the same patients. And we all 100%. Have the same problems that we need to fix and evaluate. And it's very interesting to learn from one another because we come from different parts of the world. So in Brazil, they do more ultrasound. And we do more fluorodiphecography. In Stanford, you do MRI diphecography. And just learning about sort of different way of evaluating the same thing and the advantages of one thing versus another is quite interesting.
I agree. I think it was fascinating to take cases of patients that we all see in our clinic and then, figure out how do we evaluate these patients, and we all do it in a slightly different way to kind of come up with treatment plans and management plans. What about you, Leila?
It was also interesting to me to see the audience diversity, to see how many of the participants in this workshop included of the physiotherapists, the colorectal surgeons, the urogynecologists. And so again, it speaks to the need for having multidisciplinary approach and how to really put all these test findings into the clinical context.
Agreed. I think that, pelvic floor dysfunction is such a broad term, and when you ask, well, who takes care of pelvic floor dysfunction? Well, so many different specialists and so many different people. And so when you say, well, I'm a pelvic floor specialist, well, it could, be a GI, a colorectal surgeon, a urogynecologist, a physical therapist, a urogyn or a female urology nurse. And so I think having all of us up there on stage talking about the differences in our practices and how we kind of manage these patients or evaluate these patients differently, which kind of guides our management. So one of the questions that came up was, when do we start to do pelvic floor testing in these patients, right? Because you have a patient who presents to your practice or who comes into your clinic, and you don't want to do all these invasive tests right away. You have to kind of figure out, tease them out and figure out what's going to help me make this decision. So what are your thoughts on that, Anna?
So we talk about it all the time, and when we teach the fellows, that's something that comes up quite routinely because it a little bit depends on availability of testing. So if you have testing that's readily available and your patients come from far away and it's a second or third opinion, that may drive testing to be early. Versus if the testing is a limited resource and you really can only use it for some of the patients, maybe they have to pay for it, maybe it's just not available. I think that there are a lot of things that we can do with a physical exam. We can gauge from history, and a lot of conservative management that we can actually do before we turn to any kind of testing. And in the United States, and we talk about this in clinic all the time, is the ultrasound is very underutilized. So I think that's something I would love to incorporate more into my practice.
I agree. I think that, first of all, you're right on the money that when patients come in, we always, you know, have to evaluate them. Is this someone who has tried a lot of conservative options first, or really has more of a complex picture that you think testing is going to get you to a management or a treatment solution, or or is it a patient where you think that conservative management, whether it's changing their bowel, changing their bowel regimen, referring them to a physical therapist, or for biofeedback, starting them on some bladder relaxant medication, starting with more conservative options before you do the more invasive testing. And I think sometimes that's a little bit hard to tease out in our practice. But one of the things that I also learned in the workshop is that pelvic floor or total integrated ultrasound is certainly becoming more popular, and you can see, it doesn't require an x-ray, it doesn't require patients to do any oral contrast, it doesn't require an MRI, and so that makes the test a little bit cheaper, and then also a little bit more accessible for patients. And I know, actually, Layla, you started to do more ultrasound in your practice. Right. What has been your experience with it?
Yes, and coming back to your initial question, I think one of the more important aspects of what order or which test to order will be what's the patient's take, and I feel that this is a question that should be answered by the patient also, to see what are their goals and what we learn from these tests that we order, how can we apply the findings of them in their management. And so oftentimes patients get very excited about doing an MRI, and maybe it's because the name, or it's the idea that you will get the whole picture of the pelvic floor. But we did a survey. We asked our patients who had undergone anorectal manometry, MRI, the echography, and the ultrasound. And it was really eye-opening to see that most patients really love to do the ultrasound, and they did not think highly of the MRI. And so I think educating the patients about these tests is another important aspect of what we do, because when we just tell them, for example, in my practice, we are going to order an MRI, they get excited about it, not really knowing what to expect, and so what are the details of the test. And so placing all these on the table for the patient and really getting the patient to understand what are these tests, the details that are involved, is going to be important, and will determine how the patient's expectation will be, and how to really manage those expectations prior to test, because many of these tests also have an emotional component into the performance of the patient. So if they are doing the MRI and they are really upset about the whole process of the enema prior to that, they have to poop in the diaper, which is not really quite easy for many patients. These are, and if they don't know about it, it's going to be much more difficult. Or when I'm there doing the ultrasound with the patient, talking to the patient, is much more acceptable for the patient to be pursued to do the maneuvers that we want. So I think there are too many details into these tests, and perhaps all important in terms of the findings of the test based on the patient's performance, and very hard to really go by which one is the best test, but discussing all these details is going to be very helpful.
I think you bring up a really good point. We have sort of three different modalities that we use for our purposes in terms of defectory dysfunction, which is fluoroscopic defecography, MRI defecography, and total integrated ultrasound. And they're all very different, and the patients should kind of definitely, that shared decision making and counseling beforehand should definitely be performed before the patient even walks into the room for the test. The other thing is that the goal of the test is really to kind of enhance the management and the treatment plan for the patients. And so the best test is the test that you and your colleagues feel most comfortable performing, yes, and the one that's going to give you the most information. So for example, Anna and I do a lot of fluoroscopic defecography because that is what our institution, we have great radiologists, we have good collaboration together. And so when we get these tests, they're done really well. The patients understand what's going to be happening. Sort of we trust the radiologists, they trust us, and so that collaboration really makes us confident that we're getting the appropriate test, which is going to help us in the treatment and management of this patient. But similarly, if you have a great relationship with your radiology colleagues, if you do MRI, or if you do ultrasound, that's ultimately going to be what is going to, I think, guide your treatment, because you want the sort of the best test that's going to give you that information.
Absolutely.
At the end of the day, we sat on the panel and we had 2 colorectal surgeons, and we all agree that ultrasound, MRI, or fluorodiphacography, the management would not have changed for that particular patient, right, when they're discussing the case. So it just, goes to show that ultimately you need to do, like you said, do the test that you're comfortable with, that's available to you, and if it's a limited resource, sometimes use it only when necessary.
Agreed. And I think, all of these tests are a little bit different in their pros and their cons and what you can see on the imaging. But, and I think, as a group and as a society and collaborating with radiology societies, the GI societies, colorectal societies, we can sort of advance the research into these 3 modalities and kind of figure out, what should, is there a imaging modality that should maybe be first line for these patients. We currently don't have that right now. Most of our guidelines say that there's no, we don't, no preference, and it's really up to kind of the physician or the provider what's going to work best for them. So that is something that I think we as a team could sort of start collaborating on and thinking about kind of advancing the field a little bit.
Absolutely, and I agree. And the big takeaway from today, I think, with our workshop is ultimately what you and I talk about all the time, and we have a very good system for that, but for somebody who is maybe in training or doesn't have the same setup of practice, is to recognize when should the patient be sent. So for your gynecologist, it's asking about those defecatory symptoms, asking about their toileting habits, about their bowel functions, and recognizing that that's the patient that may have other symptoms outside of my area of expertise, and testing or referring either way, but getting the other specialists involved. Like you said, we are as a pelvic floor specialist, we are the spider web, not to quote anybody, but it really is, because we are so multidisciplinary. And then same goes for me, to recognize, to ask questions about middle compartment, to ask questions about pelvic pain. Do they have urinary symptoms? And recognizing when these patients need to be sent for additional testing, which is outside of my area of expertise.
Agreed. And I think too, a lot of our patients do definitely need to have gastroenterology involvement, like we talked about today with that case of the patient who had really significant constipation.
Absolutely.
Like that really needs to be managed appropriately, and we need to work on that before any sort of surgical options can be discussed.
Absolutely. A team approach is really what it takes for many of these patients, rather than isolated look.
Agreed. So I think our workshop, comprehensive evaluation of the pelvic floor, showed that you really need a team effort to kind of come up with good treatment strategies for these patients. And also we have a lot of great imaging modalities, a lot of pelvic floor testing that can be done for more complex patients where you think it's going to kind of guide your decision making.
Thank you.
I see we have a question.
Yes, thank you for the discussion. For those of us who are not in Cleveland clinics or areas where we could have easier access to collaborative folks, how do you suggest, I'm a urologist and urogynecologist, how do you suggest finding neurogastroenterologists, radiologists who are going to be able to do those total integrated ultrasounds without having to learn everything yourself?
I think we can't stress how fortunate we are to be in the places where we are, where we have those resources. Depending on where you're at, I think finding like-minded specialists and other, colorectal and radiology, and building those networks I think that can be a good thing. But we have colorectal surgeons who do a lot of ultrasound. We have urogynecologists, urologists who do a lot of ultrasound. So maybe picking a modality that works for you if you do not have any access to that network. Same goes for neuro GI. I love my neuro GI colleagues, and it also makes my life a lot easier. But at the same time, we are all very well versed in the very early stages of constipation management, because we can't send everybody to neuro GI as much as we have to, because it's also a limited resource. So until the point that the patient needs something, more advanced testing, or they need to evaluate their foregut motility, or maybe they need to go on prescription laxatives. Usually, we get to be well versed in those things, and very nice handouts for patients that what are the first steps to manage the symptoms. But you're on the right track, because you're already asking those questions, right? So you're asking your questions about the constipation and about other compartments.
I think the other thing too is that there might not be a colorectal surgeon who's necessarily a pelvic floor specialist, because remember, there's no formalized pelvic floor fellowship in colorectal surgery, but there certainly are colorectal surgeons and gastroenterologists who have a specific interest in pelvic floor. And one of the, because I've had this conversation with a number of my other colleagues who've had the same experience, and what I've said to them is try and bring them together, talk to patients collaboratively, ask them if they would be willing to do like a pelvic floor conference with you once a week and to kind of talk about your patients that you send them to. And they may not define themselves as pelvic floor GIs or pelvic floor colorectal surgeons or a pelvic floor, even nutritionist, but with working with them and kind of showing your interest and sending, you're the expert in this area and kind of helping them, bringing them into the fold, I think that has made a huge difference. And that is something that a lot of the urogynes and female urologists in areas where there wasn't necessarily a dedicated pelvic floor person have started to do. Yeah. And it's been pretty well received, because, you're so passionate about these patients and they feel that passion and want to help you. So hopefully that was helpful.
Thank you. And my next question is, when do I know I need to send a patient to neuro GI?
Great question. And I like the first question you asked also, that speaks to the need of having a more trained neurogastroenterologist or the gastroenterologists who are really aware of the pelvic floor disorders. And I would say that any patient with constipation who has tried over-the-counter medications, and if you're feeling comfortable about ordering the newer pro-secretory agents or the newer prokinetics that are available in the market, if they have failed those medications, they definitely need to be seen by the gastroenterologist. And even if they have not tried, or you are not sure if which one is the right choice for these patients, because currently we have a large number of medications available specifically for constipation, I would say that sending those patients to the right GI is going to be a good option. Understanding that there are some of my colleagues in the gastroenterology that may not have the same interest as others in addressing those symptoms. And so it will be important for you to find the right gastroenterologist for your patients with the constipation. In terms of the patients with fecal incontinence, I feel that the role of GI is also very important for many of those patients, because we know that the altered bowel habits is a really highly noted risk factor for many of those patients. And so addressing the bowel issues for any patient with fecal incontinence is of high importance. And so finding, again, a neurogastroenterologist or a gastroenterologist with interest in pelvic floor disorders can be very helpful to help you to get the patient that is a candidate for surgery, like the case that we had, but addressing the bowel issues prior to surgery to ensure the success of your surgery will be very effective.
Thank you very much.
Thank you.
Yeah, go ahead. Yeah.
Thank you for all of those. I'm from Australia. I'm using a lot of, because I'm managing prostatectomy patients, and I'm using ultrasound as well. What is your time frame of their recovery? do you have the same time frames as the urologist as well? So say, because urologists will say 12 months recovery for rehab. What's your time frame before you say you need to go to surgical intervention already?
I think so. It kind of depends on the. It kind of depends on the patient's symptoms and how symptomatic they are. When we say 12 months in terms of whether it's, going to physical therapy or trying medications, trying different over-the-counter GI meds, if those patients, if they're not getting any benefit within a couple months, they're going to continue to be pretty miserable. And usually our physical therapists, our GI colleagues are going to reach out to us and you're going to say, this patient isn't making a lot of improvements. We're in a place where it's a little bit stagnant. They may need some additional testing. This is a good time to step in and do an evaluation and figure out if they're a surgical candidate. So I don't necessarily have a time frame for our patients in terms of when they end up in surgery. I would say really they should be making some progress, and if they're not, then that's when you want to turn towards other treatment options. Do you guys agree?
Well, there's that. There's also understanding what kind of therapy they do, because what we struggle with a lot is let's say whether refer somebody to physical therapy and what we expect to happen in therapy isn't exactly the same thing that happens in therapy. So really understanding what is it they do, and also seeing is the patient making progress in therapy. Because if they went, for 6 months but there was zero progress, that's either the therapy isn't working for them or they should be doing different therapy. Something needs to change. Versus, it could be a patient that is just making a very slow, steady progress, and as long as their symptoms are improving, they are happy with their lifestyle, because all of this is a lifestyle surgery that we are talking about here. So if they are continuing to improve and they are, content with their kind of velocity of improvement, it could be a very long time, but versus a patient who maybe does not.
Thank you. Thank you very much.
Great. Well, thank you so much, Anna and Layla, for joining me today. And thanks, everybody, for coming to our ICS Live Lounge. Good luck and enjoy the rest of the conference.
Thank you.
Thank you, Shannon.